Hi everybody, Dr. Manny here. What we're going to do is a little exercise for you guys, if you're interested, and reviewing arterial blood gases. Okay, let's go to number 1. Firstly, you have to know what normal is. So you've got to know the normal arterial blood gas parameters at an oxygen concentration of approximately 21%. pH, 7.35 to 7.45. PaCO2, 35 to 45 millimeters of mercury. PaO2, 80 to 100 millimeters of mercury. Serum bicarbonate, 22 to 26 milliequivalents per litre. And arterial oxygen saturation, 95 to 100%. That you have to know, otherwise you can't interpret the arterial blood gases. So if we look at scenario 1, you're asked to review a 63-year-old female who was admitted with shortness of breath. On your arrival, the patient appears drowsy and is on 10 litres per minute of oxygen via a face mask. You perform an arterial blood gas which reveals the following results. The PaO2 is 52.5 millimeters of mercury. The pH is 7.29. The PaCO2 is 68.2 millimeters of mercury. So what you're looking at here now is the patient is hypoxic. You've got an acidemia in the pH, and you've got CO2 retention indicating hypoventilation. So your interpretation of this arterial blood gas is a respiratory acidosis. The patient is hypoxic and hypoventilating. They can't get rid of CO2. Therefore, they have a respiratory acidosis. In scenario 2, we have a 17-year-old female patient who presents to the accident and emergency department complaining of chest tightness, shortness of breath, tingling in their fingers and around their mouth. They've got no significant medical history. They're not on regular medications, but because of the breathing issues, an arterial blood gas is performed. And this is performed while they're breathing room air. So when we look at the blood gases, we have a PaO2 of 105, which essentially is normal. If we look at the range of 80 to 100 millimeters of mercury in the initial slide. Then you've got a pH of 7.49, which is high, indicating alkalemia. Then you've got a PaCO2, which is low, which indicates hyperventilation and alkalosis. So when we come to our findings, we end up having a respiratory alkalosis, which is probably related to an anxiety attack because the patient is now hyperventilating, causing the CO2 to become low and alter the pH. When we look at scenario 3, we've got a 48-year-old male who's been admitted with a 24-hour history of abdominal distension and pain, profuse vomiting. A CT scan reveals a large mass causing a bowel obstruction. As part of the patient's assessment, the surgical registrar requests that you check his arterial blood gases on room air, and the results are shown below. So we have a PaO2 that's normal. 80 to 100 millimeters of mercury we said was normal. Then you have a pH which is high, indicating alkalemia. We look at the bicarbonate and it's high, indicating alkalosis. We look at the base excess, which is elevated, also indicating alkalosis. The PaCO2 is essentially normal. So therefore, what's our diagnosis or our interpretation of the arterial blood gas? What we have is now a metabolic alkalosis, probably related to excessive vomiting and losing excessive hydrochloric acid from his stomach. When we look at scenario 4, you're asked to review a 59-year-old female who's been admitted to the acute medical ward of your hospital. The nurse tells you that she appears to be short of breath despite currently receiving 3 litres of oxygen via an intranasal cannula. You take an arterial blood gas, which reveals the following results. The PaO2 is low, they're hypoxic, remembering that 80 to 100 millimetres of mercury is the normal range. We look at the pH. The pH indicates acidemia. It's low, it's less than 7.35. What's causing this? So when we look at the other components of the blood gas, we can see that the PaCO2 is 63. So despite breathing being abnormal, they're hypoventilating. They're retaining CO2. When we look at the bicarbonate is high, indicating alkalemia. And the base excess is high, indicating alkalemia, or another term, alkalosis. So therefore what we have here now is obviously a breathing problem, despite oxygen therapy. So what's our interpretation of this arterial blood gas? The patient has a respiratory acidosis because they're hypoventilating, retaining CO2. Despite breathing being increased, they're hypoxic. And as a consequence of that, you've got metabolic compensation because you're retaining bicarbonate. So the interpretation of this blood gas is respiratory acidosis, they're hypoventilating, they're hypoxic, and they have metabolic compensation because they're retaining bicarbonate. In scenario 5, you've got an 89-year-old patient who presents with fever, rigors, hypotension, and oliguria, reduced urine output. They appear confused and they're unable to provide any meaningful history. The care home that the patient came from has provided some basic documentation. You look through the information available and note that the district nurse changed this patient's catheter 24 hours ago. The medical register commences prophylactic antibiotics, provides aggressive fluid resuscitation, and asks you to perform an arterial blood gas. And the results are shown below. Now note, the patient was not on oxygen therapy at this time of the arterial blood gases, so just breathing room air. When you look at the PaO2, it's normal. Breathing 21% oxygen, room air. When you look at the pH, it's low, indicating acidemia. You can say acidosis, acidemia, acidosis, interchangeable. When you look at the other parameters, you note that the serum bicarbonate is low, indicating acidosis. You look at the base excess, which is also low, indicating acidosis. The PaCO2 is essentially normal. So what's our interpretation of this blood gas? The blood gas is a metabolic acidosis. In scenario 6, you've got a 22-year-old female who's brought into the accident and emergency department by the paramedics. She has a 5-day history of vomiting and lethargy. When you interview her, you note that she appears to be disorientated and looks clinically dehydrated. At present, you're unable to gain any further details, but the patient looks very unwell from the end of the bed. You insert an IV cannula. You send off routine panel of bloods and commence some fluids. You ask the nurse to check the patient's observations, and she notes an increased respiratory rate, low blood pressure, tachycardia. You perform an arterial blood gas on the advice of the doctor, and the results of the blood gas are shown below. And note again, the patient was not on oxygen therapy when this blood gas was taken. So when you look at the blood gas, the PaO2 is normal. When you look at the pH is low, indicating acidosis. You look at the PaCO2 and it's low, indicating hyperventilation. They're breathing quickly. When you look at the bicarbonate, it's low, indicating acidosis. Bicarbonate's being used up for some reason. And the base excess is low, indicating acidosis. So what's your interpretation of this blood gas? I'll let you think about it for a moment. The interpretation is a metabolic acidosis. You're using up bicarbonate. And you've got respiratory compensation where you've got hyperventilation. So this is a metabolic acidosis with respiratory compensation. When you look at scenario 7, you've got a 56-year-old man who was found unconscious at home with a respiratory rate of only 6 breaths per minute. And you've now got very constricted pupils. The ambulance was called and the paramedics administered some naloxone. On arrival to the emergency and accident department, the blood gas showed the following. Now note again, the patient is not on oxygen at the time that the blood gases were taken. When you look at the blood gases, the PO2 is very low, indicating hypoxia. The pH is low, indicating acidosis. The PaCO2 is high, indicating hypoventilation. Well, he's only breathing 6 breaths per minute, but he's hypoventilating as well. The bicarbonate and base are essentially normal. So what's your interpretation of this blood gas? The interpretation is a respiratory acidosis. The patient is hypoventilating because they must have taken a medication. If it required naloxone, maybe a benzodiazepam, or here probably an opioid. The naloxone, Narcan, will work on opioids. And they're hypoxic. Okay, scenario 8. You've got a 77-year-old female who was admitted to the hospital 10 days ago with a fractured neck of femur after a fall. The orthopaedic team repaired the fracture and she's been an inpatient on the orthopaedic ward ever since. The patient's nurse is becoming increasingly concerned as the patient's oxygen requirements are increasing. She's currently on 3 litres of oxygen per minute intranasally. And her respiratory rate is going up. She's tachypneic, 35 breaths per minute. And recently she started complaining of calf pain. In the affected leg, the left leg, where she fractured her femur. You review the patient and you perform an arterial blood gas, which reveals the following. Her PaO2 is low, less than 80. She's hypoxic. The pH is high, indicating alkalosis. What's causing the alkalosis? Now we have to find out. Her PaCO2 is low, which indicates alkalosis and that she's hyperventilating. The bicarbonate is essentially normal. So the interpretation would be a respiratory alkalosis because she's hyperventilating and she's hypoxic. When we look at scenario 9, you've got a 24-year-old medical student who's just returned from his elective in Ghana. In the last few days, he developed severe diarrhea, and now he presents to the accident emergency department. On assessment, you determine that he's very dehydrated and breathing very, very quickly, his tachypneic. The arterial blood gas that's performed reveals the following. Essentially, his PaO2 is normal. His pH is low, indicating acidosis. The PaCO2 is low, indicating hyperventilation and alkalosis. The bicarbonate is very, very low, indicating a metabolic acidosis. It's being used up for some reason. And the base excess confirms that because it's low as well. So in our interpretation of the arterial blood gas, what you have is a metabolic acidosis with respiratory compensation as a consequence of hyperventilation. When we look at scenario 10, we have a 64-year-old male who's admitted to the emergency and accident department with central crushing chest pain. The nurses are getting him attached to the electrocardiograph and he suddenly has a cardiac arrest. CPR was commenced immediately, and after 6 minutes he got a spontaneous return of circulation and began breathing again. An arterial blood gas which was performed on 15 litres of oxygen via a partial rebreather mask reveals the following. Despite the 15 litres, he's still hypoxic because the PaO2 is less than 80. You look at the pH, and the pH is very, very low, indicating a profound acidemia, acidosis. You look at the PaCO2 and it's really high, indicating acidosis and hypoventilation. You look at the bicarbonate, very low, indicating acidosis, and you look at the base excess, very, very low, indicating acidosis. So what's our interpretation of this blood gas? I'll leave you a few moments to review and consider. Well, the interpretation is that you have a combined respiratory and metabolic acidosis. The patient wasn't breathing. and the patient had no cardiac output for quite some time while they were resuscitating him. So therefore, what it indicates is that they're retaining carbon dioxide because they weren't breathing, apneic, and then hypoventilating, and they're losing bicarbonate because of low cardiac output, anaerobic metabolism, which creates a metabolic acidosis, and the patient is hypoxic. Well, that's the end of this presentation and review. Thanks. If you found this of any benefit to you, check out the other Dr. Manny Learn shops on YouTube and subscribe, and please recommend it to your colleagues and friends. God bless you. See you in other Dr. Manny Learn shops.